Hello, everybody. So this week we'll be going over Chapter 10, Emotional Development and Attachment. Some of the things I hope that you'll be able to take away from this lecture will be knowing what emotion is, the biology behind it, as well as the culture that would help to influence one's emotions. We'll talk about temperament. We'll look at how children will learn to regulate and how they control their emotions. We're going to look at what are normal emotions and then look at some of the emotional issues that children as well as adolescents might experience. Then we're going to talk about attachment and attachment styles, and finally talk about some of the attachment disorders. So first and foremost, let's look at emotions with the universality as well as differences. We experience fear, and fear would include your body's physiological reaction, the interpretation of the situation, communication with another person, as well as your own actions. And of course, these are parts of what we call emotions. It's those experiences that has a different range of emotions, that from being happy, sad, to angry, embarrassed, disgusted. So looking at some of the aspects, emotional expression can be a universal thing, and it's also considerably a lot of evidence that help to display one's emotions, as well as being able to understand how others mediate through by part of our culture and our language development, gender, our temperament, as well as our personality construct. So, in terms of cultural norms that when, how, and to whom emotions would or wouldn't be seen, we look at the emotional display rules, okay? And that's where children would learn early in their development phases how to be able to manage and display their emotions, basically according to these norms. So now, let's speak about the emotional schemas. These are different ways that we think about our emotions and how it might influence our experiences that allows us to show emotions. Okay. When we speak of this, we have to also look at temperament. And this is pretty much going to be talked about further later on in the chapter, but it's one of those filters that allows us to interpret our emotions. If we're feeling bashful, if a child appears anxious, or what might be more adventurous in terms of excitement, surprise, it's allowing us to know that our cognitions, our thoughts, plays a huge role in how these emotions will develop. So, in thinking about emotions, those emotional schemas will affect your experiences as well as your emotions from childhood all the way till adulthood. Remember, we talked about schemas previously, and the schema is that cognitive framework that helps to organize the world we live in by putting it into categories as well as associations. It allows us to experience things like anger, sadness. We're able to draw upon different association and memories that would allow us to know this is what we're feeling. Now, development of emotions, this being the role of ourselves, self, and others. In some ways, we start to understand how our emotion would be looking at how others are reacting when we act a certain way. So this process would be called social referencing. And social referencing, it starts at around age 9 to 12 months approximately. And pretty much you've seen a baby or a child when they begin to smile and they begin to laugh as well as when other people are laughing and without really knowing why they're doing it. Or think about textbook talks about when a child would first be introduced to someone new, and they're more likely to be friendly if they see that the parent, particularly the mom, is smiling with this person. At that point, the child is going to try to replicate what the mom is doing or what the parent is doing. And this is that visual cliff experiment that we looked at back in chapter 6. But again, just as a reminder, the infant's mother or the infant's father would encourage the child uh, to be able to come to them that would cross, what looks like to be a steep drop off from that table or the visual cliff. We have to also consider about the verbal and facial encouragements that's given by parents that would make a difference within a child's ability to whether they're going to show being calm or if they're going to get anxious. The parent is that model, so therefore the child is going to mimic mostly of whatever the parent is doing. Research has concluded that fathers actually play a large role with social referencing, particularly with physically hazardous type of situations. And this is usually because fathers are going to encourage more of the risk-taking behaviors in the first place. So an infant would be more sensitive to these cues, particularly from dad. Okay? We'll continue to talk more about how parents would help in terms of the emotions and how that influences the reactions of a child's emotional development later on. So now, development of emotions, still speaking of, we also have to look at empathy as well as sympathy. Okay? Here is terms in when a child is showing empathy, that's when they're feeling bad or feeling happy for someone other than themselves. Uh, it's what makes us start to develop and grow altruistically, so to speak, or not. So think about it this. Have you ever experienced feeling for someone else? When you see someone crying on television or a movie, do you ever find yourself wanting to get teary-eyed? I'm mushy. I can tell you that right now. I'm a mushy person. And I go through watching these different shows and all of a sudden I want to boo-hoo. Or even in terms of real life situations. I can recall just yesterday, well, not yesterday, this would be Friday, in which I got extremely emotional in terms of the COVID-19 situation. I was watching the news and they had showed this bus driver from New York who had did I believe it was Facebook Live, in which he was describing how someone came on the bus and with no regard toward others was busy coughing and hacking, not covering their mouth, not standing away from doing social distancing, none of this. The unfortunate end to this story is that bus driver died a week later from COVID-19. And yeah, I got really emotional about that, and it still touches me. But that's what we're talking about when we're experiencing the feelings of others. It's a primitive form of empathy, and it's that basis of our human interactions. This is what makes us connect to others. So when we see others in distress, we're probably going to show more sympathy. And when we show in sympathy, we're actually wanting to reach out and help and comfort that person or try to do something to make it better. So there is a difference. A lot of times you might hear people say, I don't want your sympathy. You can be empathic and realize and recognize the thoughts and feelings of others. Whereas sympathy is we're more of where you might be feeling sorry for someone. You might want to reach out and just say, I need to help you. And a lot of times some people don't want that type of reaction from you. But if you can still show an empathic response in just recognizing that someone is feeling or going through something, that is just as strong as saying, oh, I'm sorry this is happening to you. Recognize their feelings is pretty much the bottom line. All right. So now we've spoke about different types of emotions already, but we have to distinguish those basic or when I say basic, I'm really saying primary type of emotions, to more of the secondary or self-conscious type of emotions. Babies are going to demonstrate basic emotions during their first year. They're going to cry when they're hungry or feeling alone. They'll be able to start recognizing happiness, but that doesn't come until they're approximately 3 years of age. They'll start looking and seeing other type of emotions as they get older. Okay. Secondary emotions like pride, shame, and guilt really doesn't come later, because it really depends on the child's experiences that would allow them to understand what it is um, that they're feeling and going through. Those secondary emotions would have to have children think about events and how it affects their thoughts of themselves, as well as how and why that secondary emotion exists in the first place. And it's what we call that self-conscious emotion. These emotions like embarrassment, guilt, shame, they're not going to start showing until around 3 years old. And more or less, it's when a child start recognizing those differences between that basic emotion to the difference of secondary emotions, and know that those secondary emotions will probably be a little bit more subtle, and in the learning process will need more explanation. So understand the textbook talks about how there is a distinction between guilt and shame, and it's where we focus on the self as well as the other focuses on behavior. Okay? Shame is more for you, guilt is more for the behavior you're doing. Okay? Now, in terms of temperament, told you we'll get back to this. A lot of us often might be frightened when we watch a horror film. Well, I think I've told you my story. I don't get frightened from horror films. I love horror films in the sense that I like to rewrite it within my dreams. Oh, I'll jump and I'll get scared, and sometimes you catch me covering my face and eyes and peeking like this. But overall, I enjoy horror films. But there are some who will be so afraid that they might not ever watch another horror film again. Or if they know that it's going to enter their dreamscape, they may find themselves avoiding horror flicks because they don't want to start dreaming about it later. While, while there are those who are scared and excited like me, it's weird. Our temperament allows us to predict how we will respond to those type of experiences in the world. So whether that be a horror film, or you might be afraid, luckily for you, you no longer have to do a group presentation, but I can imagine how some of you really didn't want to go through the process of doing a group presentation, for the simple fact that that meant you had to conduct public speaking. Now, I'm one of those individuals who, through a lot of work, a lot of training, a lot of cognitive behavioral therapy, so to speak, or exposure therapy to be precise, I also struggled with public speaking. I didn't care for talking in front of other people because I had a bad experience as a kid. I got booed off the stage when I was singing a song and forgot the words, and it stayed with me. And it wasn't until I worked toward becoming a psychologist, and was in my doing my internship, that my supervisors all realized, oh wow, she really has a social phobia going on in terms of public speaking. So the response and answer to that actually was, let's throw her in. I had to do presentations almost weekly. Eventually, the final pushover to help me get over that fear and those emotions and anxiety that was tied to it was coming to Jackson State and start teaching. And that was way back in 2004, where I started as an adjunct, and here I am today talking to you. So it's something that, although the different experiences might evoke different emotional responses, that concept of temperament will imply about individuals having a general emotional style that'll help them respond in different ways to a whole lot of different situations that's within your environment. So realize that there are people who might be, again, afraid. There's some people that it just comes natural to them. I have a friend. We went to school together. He loves the gift of gab. He's never had a problem with doing public speaking. So for it's not going to be the same. And when we talked about that universal, here's where those differences are going to kick in. Not everybody's going to react the same way, and our temperament is going to be based upon our life experiences and what's going on with us. Okay. So with there being different approaches and thinking about how in psychology we would try to measure temperament, you have the Ch10 model. Okay, it's where their work is based off of structural interviews that they had with parents, and they identified 9 different characteristics that would contribute to temperament levels within children, that being their adaptability or approach, withdrawal, attention span, distractibility, intensity of reaction, the quality of the mood, how regular something is, as well as the threshold of their responsiveness. And pretty much this model helped guide them to get more of an understanding about temperament and how it develops within children. So, looking at temperament a little further, we know that with infants, they go through what we call an easy temperament, and this is pretty much generally having a good mood. They usually adapt to change pretty easily, and it's more regular and predictable in their patterns, particularly when they're eating and when it's time to change their pampers or when it's time for them to go to sleep. We kind of can gauge that. So uh, here, Chester Thomas felt that this is more of an easy type of temperament. Whereas things start to go into contrast during the difficult temperament, in which children here will start to show more negative type of moods. They're going to show how they become easily frustrated when they don't get their way, especially. It becomes harder for them to adapt to change, and now you're going to see irregularity within their patterns about how they eat, sleep, and go to the bathroom. Potty stages during this time. And I can share my experience, and my sons will kill me because I'm sharing it with them. But they were all late bloomers. I was one of those people didn't believe that you had to force a child to learn to go to the bathroom, because I felt, and later on when I became a psychologist, I felt I was right, that when you force it upon a child without them being curious and wanting to be independent on their own, that they can become anal retentive. And we'll talk about that it's a Freudian terminology through psychoanalysis. But more or less, it's during that time you see a child uh, develop differently. It's where my sons, I have 3 sons, and 2 of them finally let go of their diapers at 3, and then I have one who actually remained in the diapers till they were 4. Um, and yes, it was a struggle. Whereas I also raised my niece for the first 5 years, and she was able to get right out of them at 2. It's like through modeling, she saw me going to the bathroom. She was like, "Oh, I can get rid of this mess on me," and she took off that pamper and never put it back on. Her temperament at that point for that particular situation was easy, but still in the easy mode. But she became more difficult in other ways. But that irregularity, they're learning the word no. Understand, they're starting to become independent, and so they get easily frustrated when you try to tell them or guide them to do things. they already feel a sense of self, so they're kind of like, no, no. Um, my middle son, we always laugh, and he's in his 30s now, and we still to this very day laugh at a situation in which I try to force him to eat liver. Now, usually he's a very compliant child. He was a very compliant child. But it was that one time he was like, no, no. And he hollered it, no. Like I said, to this day it makes me laugh. It makes him laugh. But that was what I would call and categorize as one of his difficult times with temperament. Your third one is talking about slow to warm, and this is where now change is kind of difficult to introduce to a person. Going through new experiences might be difficult, and there might still show some irregular situations to how they approach and answer that. It's these patterns, they show these difficulties, but they'll gradually come around on their own. Um, Children who are slow to warm, they don't have any as much irregularities. I cannot pronounce that word today. Irregularities. There we go. In their eating patterns or sleeping or elimination patterns, but it's not considered easy, but it's not difficult. They're kind of in between. All right, so there's a second influential way that described and measured temperament, and this is from Mary Rothberg, um, who did some additional research to Thomas and Chess's work. Uh, but she kind of put a more emphasis on the neurobiological basis of temperament. Pretty much, she defined temperament as being biologically based, especially with differences in reactivity as well as self-regulation. However, she do see that these characteristics have been influenced by experiences and does show changes over time. Now, with her research, babies have been identified with three higher order factors comprising of extroversion, negative emotional effect, as well as self-regulation. And the role of the self-regulation will be in the form of effortful control and how it plays later in terms of what we're talking about in the chapter. Effortful control is characterized by a temperament that becomes increasingly important as a child gets older. Negative effect as well as the inability to self-regulate has been associated with both internalizing as well as externalizing issues that comes later on within a child's development. That being particularly depression in adolescence, as well as attention deficit hyperactivity disorder. So now, when we're talking about regulations of emotions, newborns have very little ability to regulate their own emotions. And it doesn't happen until the mid of the first year. In our brains, at that age, the frontal lobe is not developed enough to be able to regulate emotional impulses the same way it would be for us as adults. So a result of that would be that infants have very little to no ability to modulate the reactivity to any type of external events that's happening. The only thing they know is that they're feeling and what they want is what they want at that very moment. They seek that gratification immediately. Whereas there are infants that have first attempts to emotional regulation, it involves more of that self-soothing type behaviors, like the thumb sucking, holding on to their little blankie or teddy bear, you know, which helps them to avoid any kind of fear or frustration. Uh, They also, when they don't like something they see, just tend to look away. So in order for them to learn how to signal those subtle ways like we do, like usually when I get frustrated, aggravated, everybody says they can see it in my facial expressions. I demonstrate my emotions uh, through facial expressions. Like when I'm angry, it's like you could tell when I'm angry. Let's just say that way. But it allows them to also be able to learn how to signal when they're being overstimulated. So if a child is playing, for example, and they suddenly start to yawn or they stretch or they start turning away, that's a signal to let you know that they're feeling possibly overwhelmed by what they're doing, and they're becoming avoidant by saying, I'd rather just go to sleep. Um, but as a parent or a caregiver, or even those within school environments, because daycares, they take care of babies too, to and reduce that amount of stimulation, we have to try to be sensitive to those signals, and whether or not those signals are letting us know that it's for hunger, whether it's for them being sleepy, or they might have to have their diaper changed. But it allows the infant to start to learn how to regulate their own emotions, because they see this as their communication, and they know that he or she really don't need to get frantic in response when their caregivers are trying to act accordingly. Now, John Gottman, I'll change it to that, described two ways in which parents can teach children how to deal with their emotions. These styles he called them emotional coaching as well as emotion dismissing. And he starts off with the premise that regulative emotions would be more unpleasant, and that we kind of need to find a way to deal with them accordingly so that a child doesn't start having temper tantrums. Parents who are emotionally dismissing, these emotions are considered toxic, and because of that, you want to be able to protect children from those type of feelings, so that parents, they have to try to minimize the importance of the emotions at that point, rather than try to distract or cheer up a child, so that those negative emotions, when they arise, will pass and it won't be something that they feel they can use. So if say that at one point, excuse me, in order to try to do that distraction, a child gets hurt and they get upset. You ever notice when you talk to a baby, I'll say between 12 and 18 months, they fall down. Now, the trick to this was, if you jump to attention in regards to the fall down, that baby started crying and wailing. Whereas if you just sat there, you could see from your view that the child really isn't hurt. If you tend not to say anything, the child will actually just get up and go about their way and keep going as if nothing happened. That's what they're talking about, emotion dismissing. Okay, you minimize it. By, if they got a cut, you're not going to say, "Oh, you're bleeding," and "Oh, it's so bad," because that child's going to go into a panic mode. Instead, you might say, "Oh, it's just a scratch. You'll be okay." Um, and that's the kind of response allows the child to know that what they're feeling, is it is worthy but not really legitimate. They don't have to go into panic mode. All right. So now, in terms of effort control and delay of gratification, what I have for you is what we call the Marshmallow Study, which is what I'm about to play. My hope is we won't get the double echo, hence is why I'm wearing my headphones today, to try to play the videos where you're not hearing double talk. Let's keep our fingers crossed. Hopefully this will help clear up that problem, um, to bring the echo down to a minimum, because uh, these headphones are powerful. They will still pick up some sounds. Um, but I'm hoping that it will kind of minimize the muffledness and that you'll still be able to understand. So let's go ahead and watch, and then we'll continue after the video.
Okay, sit in that chair. All right, here's the deal. Marshmallow, for you. You can either wait, and I'll give you another one if you wait, or you can eat it now. When I come back, I'll give you another one, so then you'll have two. But stay in here and stay in the... Okay, sit in that chair. All right, here's the deal. Marshmallow, for you. You can either wait, and I'll give you another one if you wait, or you can eat it now. When I come back, I'll give you another one, so then you'll have two. But stay in here and stay in the chair till I come back, okay? All right. I'm gonna go do something and then I'll come back.
It smells yummy. It smells really good.
All right, so it's up to you. You can have it now or you can wait. Okay? I'll be back. Stay in the chair, okay? Okay. All right, so I'm gonna leave and then I'll come back, okay? So you can either eat it right now or you can wait. Either way, okay? Okay.
Okay, so you got to see it, and I'm thinking it's probably going to be just as muffled, so I'll probably put the link of it, because it is a YouTube video. I'll probably put that link inside the page as well, so that y'all have it, because it's a cute one, but thankfully there wasn't a whole lot of talking. But from the gist of it, you kind of understood what the Marshmallow Study was all about. It's whether or not a child can actually delay gratification. When we're talking about executive function, it's that coordinating function for the brain to allow us to choose our goals, as well as initiate those appropriate responses, or those ones that's inhibited, as well as allow us to be able to monitor our errors and our successes. So when we're talking about the development function, it's linked with effortful control, that being our abilities to consciously control our behavior. And this well-known study, it showed how 4-year-old children, these were 4-year-olds, was told to, if they could eat the marshmallow right away, they wouldn't get any more, or if they wait, they would get a second one. Well, as we can see, a lot of the kids were at the 4-year age was able to play with the marshmallows. Some of them nibbled on it. They were like, okay, I tried, but I got a nibble. I won't eat it all. And then you had the one toward the end. She was like, I don't have to. I don't have that control. She ate it. So don't remember in terms of its effortful control is being consciously aware of controlling what we do and the delay of our gratification. So now I just want to talk a little bit about long-term outcomes of self-control. Our development in terms of self-control starts with when we're young, and for young children, there's a number of positive outcomes if children grow older, as children grow older, because self-control is really an important role for development in terms of our emotional intelligence. Emotional intelligence is involving the understanding as well as controlling of one's own emotions and being able to understand those emotions of others, as well as being able to use all of this in terms of how we go through life and how we interact successfully with others. Now, the type of emotional coaching that's described earlier is really important in terms of how helping children develop this understanding as well as sensitivity will play on how they will be as an adult. So they'll learn how to be able to better regulate their emotions and how to be able to understand as well as empathize, know when sympathy is important in terms of when they're interacting with other people. And this ability allows them to separate as well as distinguish from other cognitive abilities, but it doesn't really differ between boys and girls per se. Children who are able to regulate their emotions as well as their behaviors will be seen more social as well as academically competent. These kids will be more agreeable, they'll be more sympathetic, and they'll also demonstrate a level of resilience, which we know resilience is a key factor in being able to contend and deal with different situations in our lives. They'll be able to interact with their peers. They'll be helpful. This is how leadership skills start to develop. So in terms of emotional regulation, we also know that it's kind of been linked to lower levels of problematic behaviors. And there's several behavioral disorders that we will discuss later on that, like conduct disorder and oppositional defiant disorder, that we'll go over, where self-control is minimal. Now, I always love the term normal, but we're going to take a look and discuss normal emotions as well as emotional issues and problems. So when there is this experience and expression of emotions, as I mentioned, this changes as a child grows older. Here we have to look at the different patterns of development in terms of children dealing with fear, sadness, as well as anger, and how it can be a difficult time for a child when they're experiencing it. You know, at this point, regulations of emotions is still in development. So how they handle the emotion as they come up with different situations will vary. These difficulties in regulating and using regulating their emotion and using executive control strategies really comes with and is associated through externalizing behaviors, that being where children will act out there in the environment that they're in. Temper tantrums is a good example. Or internalizing, where these are more self-directed type of behaviors. In the child's experience, those painful emotions, they might do a lot of things that might help hurt them. So when you find a child like this cutting on themselves, slapping or hitting themselves, you can consider that internalizing those problems and issues. So when it's talking about difficulties with fear, anxiety, sadness, as well as depression, these are going to be associated a lot with those internalizing behaviors. Whereas anger and aggression is more times than not going to be externalizing behaviors, because the temper tantrums, throwing things in that situations. So we'll look at some interventions that's been used to kind of help children who's had difficulty managing their emotions. Now, of course, I have another video for you. Doesn't hurt to break up the monotony. I know that my voice is soothing and such, but sometimes you need to hear from others. So this next video is going to be talking a little bit about anxiety, but I decided that at the sign of times that this video is really current in terms of how we should be working with kids during the COVID-19 crisis.
The World Health Organization has given some advice on helping children to cope with emotional stress during the COVID-19 outbreak. We have stated the exact advice in the rest of this video, advice correct at time of filming, and more information can be found on their website at www.who.int. Children may respond to stress in different ways, such as being more clingy, anxious, by withdrawing, by being angry or agitated, or bedwetting. You should respond to your child's reaction in a supportive way. Listen to their concerns and give them extra reassurance, love and attention. Remember to listen to your children, speak kindly, and if possible, make opportunities for children to play and relax. Try and keep children close to their parents and family and avoid separating them and their caregivers wherever possible. If separation does occur, for example, if someone goes into hospital, ensure regular contact by phone or messages and give them reassurance. Keep to regular routines and schedules as much as possible, or help create new ones in a new environment, including school or learning, as well as making time for safe playing and relaxing. Provide facts about what has happened, explain what is going on, and give them clear information on how to reduce their risk of being infected by the disease in words they can understand, according to their age. This also includes providing information about what could happen in a reassuring way. For example, if a family member or the child may start feeling unwell and may have to go to hospital for some time, so doctors can help make them feel better.
All right, so I think the video provided a lot of good tips in terms of how we can help children work through the COVID-19 crisis. But in terms of fear and anxiety, there are some predictable age-related changes that a child go through when they're afraid. Fear, like everything else, that they could be afraid of loud noises, or they might, in the environment they're in, might have to deal with situations like they might be afraid. I had my son when he was 3. For his 3rd birthday, his uncle had got him a truck where it looked like a lion or a tiger. I can't remember exactly which one, but the claws, it was one of those trucks where as it was moving, the claws would come out and actually move the vehicle. That freaked him out. He was afraid of that. Another thing he was afraid of was Pee Wee Herman's Big Adventure. One scene. He enjoyed the rest of the movie, but he was afraid of Big Marge in the truck because her face was squishing, eyes. It was just, yeah, he didn't like that. So in dealing with that, I have to say I was a horrible mommy because I exposed him to it further. I would make him watch that scene because I didn't want him being afraid. I would share with him, it's not real. You don't have to worry. That's not going to happen to you. But typically around 7 months of age, a child would demonstrate these kind of fears. And as the child goes through their toddlerhood, that fear of the dark, or if they're afraid of monsters under the bed, these are some of the more common types. There was a study by Maris, Merkelbach, Gatlet, and Muloff from the Netherlands who looked at least 3/4 of 4-year-old children and interviewed reports in terms of the experienced fears, worries, and scary dreams that they may have had. Now, the fear of separation from a parent was a peak for 4-year-olds at that age of 4. However, it decreases when the child got older. So while test performance anxiety was low among young children, it increased as the child became older, particularly with 10 and 12-year-olds. Um, so what we have to realize and understand that when we're speaking about fear and anxiety, this is usually going to be something specific that the child is afraid of. It's the anxiety builds because they're really not understanding, and it's that vague fear that starts building up into dread. They don't know how to deal with it, like the loud noises or the novel items or a stranger, or separation anxiety. When we're talking about the toddlers and preschoolers, they're going to start seeing things like monsters under the bed, dealing with those type of fantasies that might be frightful for them. Know that fear do increase though at age 8, and then it starts to kind of decline, and they'll go into, you ever felt invincible? I feel that toward closer the child gets toward adolescence, they start feeling more invincible. They're not as afraid of things anymore, and that feeling actually goes throughout adolescence because you become more experienced in the world and understanding what's real and what's not real, and then it recedes again as and changes as we become adults, as morality sets in. We start understanding it in a different context that way. Now, the difference between fear and anxiety is really not going to always be a clear cut thing. Generally speaking, fear is a response to a real event. It's going to be where the anxiety comes from anticipating the event happening or not happening. And on certain levels, fear and anxiety will from time to time be normal. But there are times when the anxiety can become so great, like I said, in terms of COVID-19 right now, this is a scary time. Other events that had happened in history is 911, 9/11, or if we talk about Katrina, how to work with our children during those, and because these were events that interfered with everyday activities, that will make a lot of stress, and that's what's called an anxiety disorder. So while the exact cause of the anxiety disorder really isn't known because it could be different for each child, we do look at heredity as well as temperament and how they handle stressful situations, as well as looking at some biochemical type factors that might play a role. So the textbook gives you an example about how people with generalized anxiety kind of reported feeling their emotions being more intense than others. and that more emotional reactive to negative events is what they would experience, and they felt less in control than their emotions were. Now, in science, we utilize functional magnetic resonance imaging, or fMRI. It was able to show that the amygdala, which is that portion of the limbic system, has a big part in the processing of our emotions, especially fear. So that's a note you want to probably write for yourself, because that probably will be a test question somewhere. However, the hyperactivity that's in people with anxiety disorder is going to make it more difficult for people to kind of control the experience of fear and anxiety. So when there's a vulnerability to leading to anxiety, we might tend to run to our families, or we look at our families in terms of, am I just like my mom? There are some genetic mix that might or might not result with this anxiety disorder. So, and it depends on whether that person's life experiences help to lead up to it. The best thing, though, for a child that is anxious is really to ignore the child's fears and help them to grow out of it. Okay? Now, in terms of sadness and depression, yes, I have yet another video that we're going to watch, and then I won't go into too much. I think the video will say it all, but I will point out ahead of time that sadness is a normal response for our loss and disappointment in terms of people or things, and understand that it goes beyond those feelings of sadness to where it becomes pathological when we feel a sense of worthlessness or helplessness. And children can feel that way as well. And it's really important for us to kind of catch those cues, because it can lead to suicidal ideations as well as planning and attempting. So that's something that we really need to recognize and understand in terms of children as well as adolescents. So without further ado, here's the video.
Children and teens can suffer from depression just like adults. And the important thing is that we understand that and we're aware of that, and then that we know that there's treatment. Depression is different for everybody, but what we look for are changes in sleep. You know, sometimes they sleep more, sometimes they sleep less. We look for sadness and irritability, statements like when they feel not very worthwhile. We start seeing changes in socializing, such as wanting to isolate and withdraw a little bit more. So when you start seeing a lot of those signs, you start getting concerned about depression. I think the first thing to do when you're concerned about your child is to communicate. And to, you know, if you're aware of your child and her personality, and then you're communicating with your child. But the next step would be to communicate with, say, your pediatrician, and to ask people, you know, who are knowledgeable about these types of issues. And then the last thing is that, again, treatment is out there, it's available here at Children's Behavioral Health, is to get an evaluation and to talk to somebody who's an expert in depression. You're the expert in your kid, but we're the expert in mental health illnesses.
Okay, so just to reiterate, when it comes to depression with children, I do want to make note that yes, they may show signs of sadness, but a big indicator is being able to see the other symptoms that was mentioned, that being the isolation. Child, or especially teenagers, tend to lash out a little more. They may, whereas they might have been a sociable person, then all of a sudden you see they stay in their room more. You might find them getting very irritable, and you can ask a simple question and then all of a sudden it's a snappy response. And any patterns that you see that is abnormal for that child or teen, you have to take that into consideration, that something else is really going on. And for a parent should be, like he mentioned, communicating. But as a clinician, sometimes what we have to do is work with the family. if they're noticing this, helping them be aware. A lot of times it's not that a parent is being neglectful, but sometimes the signs are just not clear enough for them to realize. Open communication is extremely important, not only in times of depression, but throughout a childhood's development, because this is how we understand and know if everything is going okay with our children or not. So that's about sadness and depression, and now we're going to move on. So I know I said that was we're gonna move on, but I gotta give you this one extra thing, and this is within your textbook, so I had to put this here. In talking about sadness and depression, again, adolescents who are depressed are going to be substantially more at risk as suffering from anxiety disorders as well. So the more common mental health disorder that would co-occur with anxiety is depression. Rates of co-occurrence could be as high as 75%. And that high rate of co-occurrence usually is explained through the substantial overlaps with the symptoms that I mentioned previously, as well as we have to assess each of the conditions by the fact that disorders might share a similar set of risk factors. So sometimes, like I mentioned, it's not where it's easily readable as we would like to think. Adults are more attuned to their emotions and they're able to regulate it better. Therefore, they're able to present it easier than what we would see in a child or an adolescent. So we would look at things as a psychologist. I would look at things about family history in regards to these disorders. I would look and see if there's any type of issues with information processing or if there's any biases that's attached. Looking at the predispositions of whether families demonstrated anxiety disorders or depressive disorders. Another thing we might have to consider is whether or not the disorders are linked in a type of sequence. And that meaning if the person is suffering from anxiety disorder, can it be a contributing factor to them later developing a depression? In the case of someone, let's say a child who really is not understanding what's going on with COVID-19 crisis, and right now we're in a stay-at-home mandate. So therefore, the child is not understanding why mom or dad is not allowing them to go out to play. They really don't understand why they have to stay home and be homeschooled. And all of this raises a level of anxiety. What it then moves into, though, because they're anxious and they're not sure about what's going on, they start feeling helpless. And that feeling of helpless is one of those key predictors that demonstrates what a person will start presenting as depressed. So these are conditions that, we have to utilize and know that they both can be treated. And there's several different medications that may have to be called into play. Hopefully we won't have to utilize that, but we can also work through what's a well-known intervention would be cognitive behavioral therapy, and that's going to be, where it's has demonstrated success in both depression as well as anxiety. Now let's move to anger and aggression. This is one of those areas that can get, really confusing, not only for adults but for children as well. Some of the problems that we see with aggression has been with impulsivity, and that's been described as some of the more persistent and common forms of maladjustment in children. Fortunately, though, a lot of children, they learn to control their anger as they become older. But there is a small percentage of kids that will have those high levels of aggression that will continue through their development. So most children will display low and moderate levels of aggression. Like I said, in toddlers, they start with that no, in the sense of becoming independent. They don't want guidance anymore. They want to be able to do everything themselves, as well as when they are having difficulty sharing in those type of situations. So this, though, will decrease as time goes by, but there are a small group of kids that maintain these high levels of aggression from their toddlerhood all the way into the ages of adolescence. And when levels of aggression stay high like that, usually it's going to be associated with when you see a child having problems academically. They may have interpersonal difficulties where they're having problems interacting with other kids. They might have what the textbook labeled as peer rejection. And this unfortunately continues until there's more criminal type activities presented. In terms of aggression, this is considered a primary symptom for oppositional defiant disorder. It's for disruptive mood dysregulation disorders, as well as conduct disorders. So what I'm going to do is we're going to take a look at each of those individually. Now, when we talk about oppositional defiant disorder, or ODD, here the child is pretty much from time to time is going to try to assert their needs in an autonomous way by that no, and doing behaviors that would be where if the parent try to tell them something, they're constantly trying to fight with the parent and, so to speak, be more confrontive and defiant. And there'll be more arguments that becomes a persistent situation as far as their behaviors. In a child, they may have these behavioral disorder of ODD. In terms of, it includes 3 types of symptoms that we would look at. That being, they'll demonstrate anger or irritability in their moods. They're going to be more argumentative, demonstrate defiant behaviors. And because these symptoms would include a fairly amount of behaviors like temper tantrums, arguments, refusing to comply with adult requests, as well as aggression toward peers. And we know when these behaviors have moved beyond this normal range, it becomes a disorder in terms of the challenges. It's like if we can't talk a child down or convince a child to calm down or to start behaving appropriately, that is when we see the severity of it or the challenges increasing. The frequency and severity of the occurrence is how we go about making those diagnoses. So with oppositional defiant disorder, it's usually identified during preschool children, but it can also appear for the first time during early adolescence. And that early onset is really associated with ineffective parenting and a difficult temperament for the child. Some of the interventions that would help parents, it would be to help them to provide structure within the household, and that means helping them with daily routines, having them demonstrate and show success when the child is acting appropriately, and if they begin to start school, to kind of keep that going forward in that sense. In terms of talking about late onset oppositional defiant disorder, teens typically will have families who have done at least a marginally good job of being able to set limits with their kids as well as monitoring their behavior. However, the parental monitoring kind of waned off as they started reaching adolescence, and sense that they felt that the children have all what it takes, and now they allowed the children to take the reins, which can influence deviant behaviors, particularly if they're hanging out with others who's deviant. And this has been able to allow us to see that it draws the teens into those behaviors. Now, disruptive mood dysregulation disorder. This has been diagnosed in children between the ages of 6 to 10 years of age when they demonstrate a severe and recurrent temper outburst, which is really out of proportion in terms of intensity as well as the duration of what may be going on. And the time it's happening is not just once a week, but it's showing up about 3 or 4 times a week. Kids with DMDD, they demonstrate symptoms of irritability as well as anger, and it's most of the time, and it's happening through various situations. And this is really a newer diagnosis that's in the DSM-5, and there have been some controversy over whether it's really a unique or independent diagnosis, but considered more severe than oppositional defiant disorder. Its primary symptoms would again demonstrate irritability and anger, temper outbursts, and they're shared with a number of other disorders. There was a recent study that looked at the DMDD symptoms in children from 6 to 12 years of age, and pretty much they reassessed the children later on, about 8 years later approximately, where only 29% of those children demonstrated these symptoms where the problem first was assessed. And it remained a problem only at the end of the study. That after that, a child basically grew out of it. This newer category is going to be continued to be scrutinized based upon reliability and validity, and whether or not it's a useful diagnosis for clinicians. Now, conduct disorder. Here, this is when we talked about looking at DMDD and how it was first diagnosed between 6 to 10 years of age. Here we got to look at, in terms of the cognitive disorder, it's something that is a repetitive and persistent pattern of behaviors. More or less, these children, it is usually diagnosed within the same range of 6 to 10 years of age. There's a lack of respect with these kids. They demonstrate not only irritability and anger, but they demonstrate that they really don't care what you feel or what you think. They're aggressive toward people and animals, and the basic rights of others is really negated and violated at all levels. Okay, this is one where they might start the criminal behaviors. They might go and, shoplift, get into fights with other children, destroy property. This is the one that's a predictor for whether or not an individual will grow up with antisocial personality disorder. So, in terms of conduct disorder, it's one of our more serious disorders that we look at. And more or less, when later on in life, if we have an adult that presents with antisocial personality disorder, we kind of look back within their history to see if they were ever diagnosed with conduct disorder. And one thing to say, if a child is given a diagnosis over the age of 10, that increases the likelihood that antisocial personality disorder will happen for that person. Now, with all of this, we have to take a look at how attachment plays a part. And so we're going to look and talk about secure attachment. You know, love is one of our strongest and most formative type of emotions for us to have. That first love that we'll develop usually is for our parents. And love is what helps to develop our relationships because it helps to strengthen the emotional bond. This is what we call the attachment, okay? And pretty much it is what is circumsum to our well-being as a person as we grow up. So we look at how the different how attachment develops. We need to see the differences from person to person and understand there's going to be differences. But we look at what those consequences might be based on the type of attachment that they present with. So realize that attachment is that emotional bond that's going to be central to our well-being as a child grows. And looking at how it helps to satisfy our needs, it allows us to see for infants and young children that there's an exploration that comes with it as they grow older. And when we talk about secure base of exploration, this is when we're saying how the children will feel safe in exploring and learning about themselves as well as others. And that's all dependent upon how they receive the care from their parents or caregivers in the beginning. Alright, so of course I have yet another video for you to see, but it's going to be helpful to you, and I promise I won't be speaking too long from it thereafter. I'll let you watch it, and then we're going to move right forward.
The attachment theory argues that a strong emotional and physical bond to one primary caregiver in our first years of life is critical to our development. If our bonding is strong and we are securely attached, then we feel safe to explore the world. We know that there is always that safe base, which we can return to any time. If our bond is weak, we feel insecurely attached. We are afraid to leave or explore a rather scary-looking world because we are not sure if we can return. People who are securely attached are said to have greater trust, can connect to others, and as a result are more successful in life. Insecurely attached people tend to mistrust others, lack social skills, and have problems forming relationships. There is one type of secure attachment, and there are three types of insecure attachments: anxious ambivalent, anxious avoidant, and anxious disorganized. In responses to distress, the first three react organized, while the last acts disorganized. To understand the theory better, let's look at Mr. and Mrs. Smith, who have 4 children: Luca, Anne, Joe, and Amy. The Smiths are lovely parents who cuddle, make frequent eye contact, speak warmly, and are always there for their kids. But one day, Mr. Smith falls very sick and dies. For Mrs. Smith, life now becomes very difficult. She spends all day working, while at the same time trying to care for her children. An impossible task. At 6 years of age, Luca's brain is for the most part developed, his character strong and his worldview shaped. The new situation does not affect him much. He knows there is still always Mum, his safe haven. He feels securely attached. Later, he turns into a trusting and optimistic young man. His self-image is positive. Anne, who is 3, has problems coping with the new lack of attention. To Anne, her mother now acts unpredictably. She is anxious about their relationship and as a result becomes clingy. To get her mum's attention, she has to raise her emotional state and scream. When her mum finally reacts with a predictable response, she herself acts ambivalent and doesn't show her true feelings. Later in life, others think Anne is unpredictable or moody. Her self-image is less positive. Her attachment style is anxious ambivalent. 2-year-old Joe spends his days with his uncle, who loves him, but thinks that a good education means being strict. If little Joe shows too much emotion or is too loud, his uncle gets angry and sometimes punitive. This scares Joe. He learns that to avoid fear, he has to avoid showing his feelings, also in other situations. As an adult, he continues this strategy and has problems entering relationships. His image of himself is rather negative. His attachment is anxious avoidant. Amy, who is just 1 year old, gets sent to a nursery. The staff there is poorly trained, overworked, and often very stressed. Some are outright abusive. Amy therefore becomes anxious of the very people she seeks security from, a conflict which totally disorganizes her ideas about love and safety. As she is experiencing fear without resolution, she tries to avoid all social situations. As an adult, she thinks of herself as unworthy of love. Her self-image is very negative. Her attachment is anxious disorganized. Our attachment is formed in the very first years of our lives, a time when we are too young to communicate our anxiety and as a result can experience high levels of stress. Then our adrenal gland, an organ sitting on top of our kidneys, produces the stress hormones adrenaline and cortisol. The heart rate increases, the blood pressure goes up, and we become alert. If that happens frequently, it is called toxic stress. Toxic because it impairs the development of a child's brain and weakens the immune system. In embryos or at a very young age, toxic stress can even switch the expressions of genes, which can affect our health many decades later. By simulating a strange situation, we can assess an attachment style already by the age of 1. To do this, we let the child play with their mother for a few minutes inside a room. Then the child is left alone. The key moment is the child's reaction when her mother returns. Securely attached children first usually hug their mother, then can calm down and eventually get back to playing. Insecurely attached children can be ambivalent and avoidant. Some can't stop crying or refuse to continue playing. The long-term effects of our attachment in the early years are well documented. Using the theory, researchers at Minnesota University were able to predict already at age 3 if a child would drop out of high school with 77% accuracy. In another study, undergraduates at Harvard were asked to assess how close they felt to their parents. 35 years later, they were asked about their health. 91% of those who said they had a rather broken relationship with their mother were also diagnosed with health issues, including coronary artery disease, hypertension, and alcoholism. For those that had reported a warm relationship, the figure of poor health diagnosis was just 45%. But there is another reason why the early years deserve special attention. They are the starting place for subsequent behaviors. A kid that feels securely attached at age 2 can make friends at kindergarten. Their worldview gets reinforced with every interaction and they develop optimism. As a result, they make good relationships at school, then at college, and later at work. Highly insecurely attached children can miss out on this opportunity. Psychologist John Bowlby, a pioneer in attachment theory, allegedly said, "What cannot be communicated to the mother cannot be communicated to the self." In other words, those who feel insecurely attached might not quite understand themselves. To get to know who they are and what they feel, they might have to go way back in time.
All right, so as I promised, we're going to move further and talk about attachment in different ways.
The attachment theory
All right, so now what I do need to stress, I am going over as much as the chapter as I can. However, I do need to make sure that you are reading the chapters because there are some parts that I've skipped and went through and went by to kind of conserve this lecture, uh, as it is already over an hour and 16 minutes. So please make sure you are reading the chapters as well. A lot of a lot of things that I've already mentioned, you will see as you're reading, and allow that to be a refresher for you. But there are some areas that I kind of nipped in the bud. So please make sure you're doing your readings. But in terms of talking about attachment as a relationship, it's based on the relationship between two people. That being, it'll have an impact on how our relationship will manifest. Interactions of a particular child and parent will create this unique relationship and bond that's going to be different from other people's relationship with that child. So the role of the mother, this here will affect that child's ability in terms of sensitivity, responsiveness, um, because of how the mother was sensitive or responsive to that child. In terms of factors, these factors can be similar to those that help through stressful situations. See the mother as likely to be able to respond positively to babies when they are having the following situations. They'll have a positive relationship with a partner. They'll have adequate in economic resources. They're going to be more resilient in that area. They'll demonstrate good mental health well-being. There's a history of good care in their own childhood that they'll relay into when they become parents. Infants, they'll be more easier to care for. All right, so looking at attachment as a relationship, fathers have really been neglected in terms of talking about research and infant attachment. But it has become clear that infants are really capable of forming a real genuine relationship and bond through their fathers, and it plays an important role in how they develop throughout life. There has been research that demonstrated that fathers are more likely to react sensitively to their sons as to their daughters, and that infant boys are going to be more likely than infant girls to be securely attached to their fathers. Now, there's been one explanation that kind of says that different types of interactions that the mother and fathers would have with their children is responsible for this. And while mothers are frequently the source of security for infant, fathers are more likely going to be stimulating that playmate for their infants as well. So there is a bond and an attachment and connection, and even to which where fathers, newborn fathers, new fathers, or fathers of newborns tend to, now help to shore up the attachment with their infant by helping in the feeding process, doing the diaper change. You have fathers now that stay at home dads. So we know now that, okay, it's not only the mother that helps to create an attachment style for infant, that fathers too has an extreme important factor. Now, we've been talking about how caregivers and parents would help in terms of developing a child's attachment style, in terms of working with through a relationship. But guess what? Babies are part of this process as well. There are babies. A baby's temperament will really affect the way a parent will respond to their child. Just as children adapt to the world and to their parents, parents have to adapt to their infants, particularly if they have children who are highly active, or they're irritable, demonstrates colic, always chatty. These are things that a parent, can either be panicked, not know what to do, or they'll be placid and calm in the process. So we can expect that a baby who's irritable, or they might show temperaments that would be deemed difficult, can be harder to be raised, which can result in more of an insecure type of attachment. Whereas it doesn't appear to be the case as we might think. Research has demonstrated that parents with adequate resources, important resources, when working with an irritable baby, really actually can lead to a more secure attachment for that infant. So mothers with irritable babies, they probably have to be more in tune to why the baby's irritable in order to kind of help soothe the situation and be able to provide them with a more secured attachment type of relationship. Now, there are other type of characteristics that infant will possess, as terms from being a premature baby, or there might be neurological issues, and these things can affect an attachment style from forming correctly, but well, not correctly, but forming as one would expect in development, because it's more difficult for the mom, particularly one who's sensitive or feeling hurt about what their child is going through, to be able to readily read those signals from the infant that's having any type of developmental delays. So, and I can give, I have a son who's under the autistic spectrum disorder, Asperger's type, and I treated him just like I treated my other sons growing up. It wasn't until there was some noticed differences, wasn't happening until he actually went to school. In terms of at home, he was a great kid, really smart, taught himself to read by 3 years old. But when he went to school and was starting to interact outside of the household, he started demonstrating the issues and problems that of a person with Asperger's would possess. One thing I can say that I think, medically speaking, that we struggled with and worried about was that he was born with what they call tracheomalacia, and that's where it was underdeveloped at birth. So it was a constant worry that he would stop breathing. We didn't want a situation occurring. But it's those type of things, having to learn how to read those different signals. I didn't have that problem or issues really as an infant, but I had to start learning more about it when he reached preschool and school age. Now, talking about biological and cultural underpinnings in terms of attachment, we've been going over through this entire textbook and in our lectures and discussions how uncovering so many of the different behavioral links and how they relate to biology. In regards to attachment, we've looked for those neurochemical explanations for development in terms of the adaptive and maladaptive behaviors. And we have read about how children who've been raised in situations marked by neglect and raised in orphanages have struggled in terms of their attachment styles. So a lot of these kids, they continue to have problems forming any kind of secure attachment due to these earlier situations of isolation. You know, they demonstrated and talked about in Romania, where you have hundreds of babies and infants in this large asylum type environment in which they only had a few nurses and stuff going by making sure they would eat, but nobody actually giving them the affection that an infant would normally receive from a parent. And thus the struggle to have these secure attachments goes throughout even into adulthood. Okay, so one thing we've seen in terms of how biologically there's some differences or some things that we have to look at is talking about how the hormonal response is influenced in terms of social interactions. Oxytocin is a chemical that's been linked with a positive feeling that comes from a connection with warm social interactions. Kids that's been raised by parents from birth generally will have a rise in oxytocin after interacting with their parents. However, previously neglected children, they really didn't demonstrate a similar rise within oxytocin following interactions with parents. So that kind of gives us an inkling that the connection and that interaction and the affection that's being provided does have influence on our brain activity, our physical and neurological and biological products are coming based upon these external type of factors. Many have produced very low levels of vasopressin, and that's a neurochemical that's linked with our abilities to be able to recognize individuals as being someone we know. It might help us to understand why children that's reared in deprived situations might sometimes run into these to any kind of adult, be that appropriate or not appropriate, in times when they're feeling stress. What's not yet really clear about the research, though, is whether or not the chemical responses are really set for life, or do it change through time and through these different experiences if a child starts to receive the affection that's needed. Researchers have also identified these differences that would show a way in a way that the children would be different in terms of attachment. And these categories is going to be toward how they react towards stress, and how is it when they're under stress would relate to the release of cortisol. And you heard in the previous video that, and we talked about stress at some sort through other courses that you've taken if you're a psychology major, but if you haven't, a lot of our stress we create cortisol. And cortisol is supposed to be a healing factor that's supposed to help soothe the body, but too much of it within our system will actually be detrimental to our health. Basically, it'll lead to cardiac issues, as well as all kind of different problems biologically. So it's knowing that hormonal system is working through with cortisol, and we're activating our fight or flight responses in the sympathetic nervous system. That can impair functioning over a long period of time with our immune systems. So when we talk about insecure attachment, there has been an association with impaired functioning of all three of those systems. Infants who are ambivalently attached tends to demonstrate the caregiver's response of when they need help of uncertainties. They become hypervigilant, and of course, if they're hypervigilant, guess what's kicking? Cortisol. So it makes for potential threats in the long run. Those who are avoidantly attached, they're relying on strategies that's going to help to relieve stress by distancing themselves from anything they think is going to be stressful. So now this system really is underreacting in the face of a threat. The fight or flight response is really not going to be activating the way it should be. Then there are those babies who are securely attached and who have the expectation that others are going to be available and help them in times of those stressful situations, and that the person will be flexible and easier to handle and deal with, and such that will have the baby be able to be willing to turn to others for help. A secure attachment helps them to be able to regulate the emotions more, and it also helps in terms of their response, physiological response to stress. So they're going to be more healthy physically, and a secure attachment style will help infants develop strategies that's going to actually help them cope with stress and develop stronger self-control. Now, we talked about Bowlby earlier, if you recall, and he kind of feels that attachment behaviors are adaptive behaviors, and that it helps to, in regards to a child or an infant surviving. This really shows how attachment should be seen through all cultures all over the world. And there's not as many cross-cultural type studies that would test his hypothesis, but many have focused on one of these two type of situations. That being, is the proportion of secured versus insecure attachments in infants similar from one culture to another? Or what does a securely attached infant look like to parents in different cultures? Now, regarding that first question, cross-cultural research has demonstrated that the proportion of infants who are classified by the strange situation of having a secure attachment really doesn't have much in terms of differences from one country to another. Secure infants will usually account for about 2/3 of infants within that study. But what's more likely to change or be different is the proportion of the infants in different categories of insecure attachment. Now, in terms of American and Northern European cultures, more common, it's going to be insecure category is going to be that avoidant attachment. Yet, in Israel or places like Korea or Japan, you may see more of the anxious, ambivalent attachment category. So there are some comparisons that would show how it could be different. And with secure avoidant and resistant attachment types, here in the US, Japan, and Korea, as well as large international samples of infants, the disorganized, disorient attachment, which really is not included in the table that's in your textbook, but it showed at least 9% of the infants, at least in Korea, compared to 15% in North America and European samples, having that issue and problem. Research in Japan regarding attachment has been really complex because of the concept of a may. And a may is an emotional interdependence between a caregiver as well as a child. And that's something that's encouraged, as we know that Japan would be more of a collectivistic viewpoint in family dynamics and how we live as a people. So it's not going to be identical to our Western concept because we're more individualistic. So our attachment styles are going to be based off that. And it's where there's been different outcomes and responses to the strange situation, but it's been used primarily in testing here in the Western, more in the Western areas than Eastern areas. All right, so now let's talk about moving beyond the infant stage. Early attachment experiences, they are important in terms of how a child develops later on. And here we're examining what the long-term effects of attachment and security is in infancy. But we got to also look at other factors, other limitations or changes that would influence early attachment or later development. When we're looking at the nature of attachment, we're looking at the relationships of children and how they move through middle childhood all the way into adolescence. Research has demonstrated long-term effects of attachment security within infancy, like Bowlby's concept of internal working models, can be predicted. So in the earlier years, relationships that are securely attached these infants will have, with parents, demonstrated soothing and being able to help the infant modulate their reactions, helping them in terms of frightening and other arousing situations. And that soothing is internalized so that the older child or adolescent, they're able to soothe themselves as they get older. So, when you feel upset about something, you can reassure yourself. Whereas in the infant stage, that reassurance comes from the parent. But on the other hand, attachment insecurity as well as disorganization in infancy has shown a relationship to later externalizing behaviors like aggression and oppositional defiance. So those internalizing problems like anxiety and depression that we spoke about earlier, it's really given us an understanding of what would be going on in the minds of a child at different times and in different types of how they would internally work through those models. All right. So the child is getting older, and at this point, caregivers' presence is not as much needed physically in order for that child to feel secure, but they do still need to have the caregiver or parent available in times of stress. So, like I mentioned, toddlerhood, that's when that independence is kicking in. And even as early as 1 year old, a child will start showing a secure base script in which his or her expectations about how to deal with stress is going to be met with some concerns, and then they want to know how is it going to be supported, even at that early age. And it includes the idea that children that's in distress, they may approach somebody to help, and who's going to be available, who's going to demonstrate being supportive, and allow that child to experience a relief as a result of the closeness. And when we're talking about a secured attached style for a child, that expectation of the support is going to be present. While with an insecurely attached child, it won't be. That secured base script that a child possesses will be where we can see it through how a child would complete stories, and we would also be able to look at what they're doing in terms of how they handle different situations or when they're asking for help. Now, researchers looked at 7 to 12-year-olds and found that there is a consistency in regard to measuring that secure base script from situation to how a child might, seek help from their parent in terms of like doing their homework, or if the child gets hurt, they're going to look. So there is consistency across those relationships. That is, those expectations that the child would have for the parent or for a peer is still going to be present. So having these positive, secure base scripts during times of stress helps a child to be able to adapt in a particular way that's going to be helpful to them, and being able to reach out to others for that help. All right, so, and I know this is child psychology, and some of you might take adolescent psychology and some of you won't. So I am going to share with you some things about adolescence in terms of attachment. And you have to know that adolescents, they might not require their parents' physical presence to feel safe and secure. But they need to have that sense that no matter what, their parents are there for them. And it helps with their well-being, that allows them to shore up that secure base that we spoke about, allowing a teen to be able to broaden their horizons as far as with the world or through social relationships and new experiences. Also, at the same time, relationships with peers, understand during adolescence, changes. Puberty have occurred. Therefore, intimacy is now also in play, as well as looking for their friends to be support networks. And this also now functions as a new way of getting attachment. Okay, so we want to know that for teens, parents are a key factor, but it's where they don't have to be present all the time for a teen to know that their parents have their back. And in terms of that commitment, it helps with their well-being, but it also helps push them to know that they can go out and create new relationships that will provide them with that similar type of support. So we talked about several different attachment styles and the theories regarding attachment. Now we need to take a look at some of the attachment disorders that's affecting some children. Understand, most children, they're going to develop secure attachments, for their parents, but they might have some insecure attachments towards specific caregivers. And it's rare, but few have had difficulties in being able to demonstrate any kind of a strong attachment in relationships that they would need help with. I'll give you one example. It's not a disorder, but in terms of getting you to understand what I mean. As an infant, I was told that anytime I was left with elderly people to be as a caregiver, that I suffered from a great deal of separation anxiety, in that I cried from the time they dropped me off until the time I was picked up by either my mom or my sister. And that no matter what, my mother went through several different caregivers until she found someone she said was young enough that I didn't mind being with them. And in fact, that actually carried through for me into adulthood. I had difficulties relating to elderly people for a while, until I met one cool one, and she changed my whole perception about elderly people, and I've learned that they were cool people just like everybody else. But keep moving forward. We'll talk about these attachment disorders. Now, the DSM-5 recognized two conditions, that being the reactive attachment disorder, or RAD, and then the disinhibited social engagement disorder. Now, both of these are based off of the fact that these experiences that's happening during infancy, like abuse or neglect, and there's an interference with the formation of a secure relationships. So a child with a reactive attachment disorder, they're not able to really form any kind of attachments toward others. And that child is withdrawn. They have difficulties with the caregivers as well as parents. And it shows pretty much a disturbance within both emotional functioning as well as social functioning. A child exhibiting the disinhibited social engagement disorder is really indiscriminate as far as where or whom they go to. Here, a child may not even seem to have any kind of special relationship with a caregiver, and their behavior is going to be the same when they're interacting with someone they know as well as a stranger. There's really no difference between the two. And it's really been suggested that this type of indiscriminate attachment actually is adaptive for the child who might have been abandoned or mistreated, because children who've had no effective parenting, that's what they do as far as their approach to anybody else when it comes to getting help. Now, one of the issues that these children do not really change their behavior even when they're being adopted or they're given someone who shows affection and care. And this is what caused the problems, particularly with adoptive parents who really don't understand where this is all coming from, these type of behaviors. So in terms of diagnosis, reactive attachment disorder, that was developed in part through observations from the 60s by Tizard and colleagues, in regards to children being raised in those kind of orphanages that we talked about, but these being in England. Now, children that were raised with multiple and changing caregivers rather than a few people, they knew and understood each child well, but Tizard observed that children around age 4, that only 1/3 of them had formed any kind of secured attachments to any kind of caregiver. All right, so we're really close to the end of this chapter, and we're just going to look at some prevention and treatment options. There was a group of researchers that developed a foster care program that would help to accommodate some of those children that was institutionalized from Romania, for example. What helped them, and in later comparing the incidence of reactive attachment disorder to those who remained within institutions to those in foster care, and to be able to control the group who had never been institutionalized at all. Institutionalized infants and toddlers between the ages of 6 to 30 months showed more signs of the reactive attachment disorder than those within the control group. But for those who were then moved into foster care, that incidence of reactive attachment disorder did decrease at the same levels as the non-institutionalized control group. So they were able to assess the children for indications of disinhibited social engagement disorder, and from that they were able to find that these behaviors were also declining. So in that case, it remained higher than the level of a control group, making it appear that those moving infants to a more secure environment would improve attachment for the children, but there may be some limits to how that improvement would happen. So at least in early years of a child's life, families that adopt children with attachment disorders, they have to understand that there's a lot of work involved in helping them to cope and learn how to reverse those negative effects that a child's early experiences would give. And though eventually these outcomes for like those Romanian orphans, they weren't positive. So it's a lot better than not having any kind of attachment at all, and it prevented attachment disorders in high-risk populations, like the children living in poverty or in abusive families. So it helped in terms of trying to fix those problems after it occurs. And pretty much that is it for this chapter. So please do the link below, follow that for your assignment for the week. And just wanted to make note and make a reminder to say, if I didn't say it in an announcement to you yet, that there has been a change in our scheduling. So there will not be separate tests for graduating seniors as it first was prior to spring break. We will now just have one exam, and I will let y'all know which date I choose, that being April 22nd or April 25th. I'm not quite sure which date I'm giving yet, but I will let you know. On that note, do remember that the assignment for this week is due on Friday by 11:59 p.m. I do hope that, I know I made a mistake last week and was asking for your written papers, and I do apologize for that, I really do. But do know that it is due today. So make sure that you do upload your written papers, semester papers, by 11:59 this evening. so that we don't have any issues or problems there. Of course, I'll take late submissions, but do know if it's late, it's an automatic grade deduction. So I wouldn't even be grading from 100. I will be grading actually at a B level, which would be 80. So please make sure you get it in. On that note, have a great week. Please do stay safe, and we will chat again next week. Take care.